Another informative and interesting conversation about something that you want to know about. But first, we need to thank our sponsor, that My Girl Managed Services. They can take your social media, your Google presence, and your website to the next level. So if you are a business just starting out, or an existing business that's just gotten a little bit stagnant, make sure to check out Jen and her team over at My Girl Managed Services. Hi, Sarah, how you doing?
Hi, Holly. I'm doing well tonight. It's a rainy, foggy night in the Poconos, so we hope that everybody out there is home, snug in their houses, and not out driving in the crazy fog. It's going to be a great show tonight. We want to welcome Dr. Ranju Gupta. Hi, Ranju.
Hi, how are you, Sarah and Holly? And welcome, everyone. Thank you for the introduction. Today is my great privilege to introduce a very dear friend of mine and a colleague, Dr. Paola Blanco. She is a gastroenterologist with EPGI. She's also the assistant professor with USF College of Morsani with Lehigh Valley Health Network. And, March is the colon cancer awareness month. So I thought it would be most appropriate to bring somebody who can talk to us about colon cancer, why, what, how. Everybody loves the colonoscopy, right? My favorite.
I have so many jokes that I'm going to have to hold back about. I was like, how are we going to introduce this one?
Yeah. So one kind of really big thing that I hear from all my patients is when I talk about colonoscopy is, can't they do anything? We are in 2021. Is there no new technology about that? But before we kind of go ahead of ourselves, welcome Paola, and just anything about the introduction to the colon cancer and why it is important to have an awareness about colon cancer.
Oh, thank you, Ranju. I really, appreciate the invitation for being here tonight. Colon cancer is definitely one of my favorite topics to talk about because, like you said, it's such a taboo. They're like, oh, colonoscopy, oh, you do that? We don't, patients don't even want to hear about it when you talk to them about the procedure, but it is the third most common cancer in both men and women. And what I'm so passionate about, it is one of the most preventable types of cancer. So just getting information on what colon cancer is, how it comes by, how can you get screening, I think that's probably one of the most important steps for patients to know, and know that once we find a polyp, which basically are these growths that patients can develop, and then that will eventually lead to colon cancer, you can decrease the risk of developing colon cancer by 90% just with a colonoscopy. So it's really one of those topics that patients don't like to talk about, but it's so important.
I know that I went for a colonoscopy and an endoscopy, and it really was not as bad as you think about it being. I think the preparation, like the day before preparation, is probably the worst part of the actual procedure. But there are some things now that you see. There's a different way of doing a colonoscopy. Is it through swallowing something, or how?
Well, if you think about, so first, let's talk about where colon cancer arises from. So okay. Patients can get sort of these growths in the colon that you don't even know that you have. Right. They're like little almost mushrooms that if we leave in there, we know that the progression will go on to develop colon cancer. So we think starting at the age of 50 is when patients should start getting screened for colon cancer. Now, there are patients who have a higher risk of developing colon cancer, and those are patients who have a family history of both colon cancer and colon polyps. If you have a personal history of polyps, if you have chronic conditions like, for example, ulcerative colitis, long-standing ulcerative colitis, you're at risk of developing colon cancer, and really anybody who turns 50. Now, African American population, slightly higher risk at the age of 45, but right now the screening guidelines is everybody who turns 50 gets a colonoscopy. Now, when patients come to see me, they're like, okay, so what can I do to prevent colon cancer? So there's sort of two steps. One is a one-step screening, meaning that's the colonoscopy. We're looking for growth, so we're detecting it at the time of your colonoscopy. We're removing them, and then the risk of the colon cancer goes down. So it's just one step procedure. The other one is a two-step procedure where basically it looks at blood and also detects altered DNA in your stool. One is called a FIT test. The other one is called a Cologuard test. The FIT test stands for fecal immunochemical test, which looks for hidden blood in the stool. And that is done on an annual basis in your PCP's office. The multi-target stool DNA or the Cologuard test, that also can be done, but unfortunately there's a lot of false positives. So those are sort of the two non-invasive ways to do that. There's other tests, the capsule, that's quite not out there yet, so maybe in the future down the road. For patients who are at high risk to undergo sedation, there's CT colonographies or imaging of your colon. But really, the best way, the American Gastroenterology Association, really, we advocate is just doing that one-step, process in getting your colonoscopy.
So Paola,
Go
let's kind of break this down, right? So you gave a lot of information in kind of one answer, but I think that just for our audience, we want to break it down. So like what Sarah said. So if we are going for colonoscopy, I know that, typically we have to drink the Go Lightly. That's kind of the most common pressing questions. Like Sarah said, that getting the test is not the difficult part. You're sedated, you are kind of go to sleep before you do anything to us, and then we wake up and the test is already done. So it's really the preparation that is there preceding the test that is the most difficult one. So Go Lightly, you have to drink, I think, 1 gallon or 2 gallons of Go Lightly.
Well, yeah, so thankfully the preparation has changed now. And so the day prior to preparing yourself for a colonoscopy, so we're looking for these tiny growths in the colon. So we can't see them if you're not cleaned out. So we need to, wipe your colon from all that stool and water. So the day prior, you're just on a clear liquid diet. So you can have, so patients are like, oh my gosh, I can't eat. Well, you can have chicken broth, you can have Jello, you can have iced tea, anything that's clear. And during that day, you're going to be drinking lots and lots of liquids. And then the preparation, it depends. We tend to use a lot something called Supret, which are really just 2 small bottles to clean you out. There's other ones that are available. There are something called Miralax Prep, where you mix powder in water as well. Plenview is another one out there, and most recently pills were also approved to clean you out. So there's a lot of methods depending on what your insurance covers, on if you have a lot of medical problems, for example, kidney disease, and so that there would be certain preparations that you could qualify for. But then once you drink that out, I always tell patients, don't do any plans, stay at home near a toilet. And then that just sort of cleans you out. It's just sort of one day of torture for 10 years peace of mind. Because if we don't find polyps, if there's nothing in your colon, you don't have a family history, then the next colonoscopy is in 10 years. Your mammogram you have to get every year, not your colonoscopy.
That is true.
So that's the one good thing. One day of torture for 10 years of peace of mind.
And no red Jello, right? No red.
Nothing red. Yeah, because you can imagine red looks like blood, so we don't want to get confused during your colonoscopy. But that's the trick, is the more you drink, the easier the prep is. And then, like you said, when you come to our center, you'll be asleep. You won't even feel the procedure. The procedure itself usually takes about 20 to 30 minutes between the recovery and waking up. The whole process is about like an hour and a half. And then you go home, and then really, there's so many times, patients wake up and I find very large polyps, or I find a mass, and they didn't have any symptoms. So what we're looking for doing the colonoscopy when you turn 50 is preventative. Patients are coming to us and they have no symptoms. They just turned 50 and this is their first screening test.
I know that when I went, they told me, I was so happy when the doctor said to me, okay, I'll see you in 10 years. And I was so happy that was the report that I got. But he did explain that during the colonoscopy, if they did find any polyps or anything like that, it would be removed at the time and then they're sent off for biopsy, correct?
Yes, yes. So at the time of the colonoscopy, the polyps get removed and then determine on what type of polyp it is. There's many kinds. The precancerous kind are the adenomas, and within the adenomas, there's different types. Those tend to be more aggressive. So then we'll tell patients to come back maybe in 3 years. If you've had many polyps, then maybe we'll have you come back in 1 year. But if you have no polyps or something called hyperplastic polyps, those are benign, then we'll tell patients 10 years. Again, taking into account that this patient doesn't have any family history or anything like that. But yay, great. So you got the 10 year.
I did. I got the 10-year, good to go, which means that I'll be, 70 when I get my next one.
Wonderful.
So-
So if you really don't want to see me as a oncologist, you got to get your colonoscopies done by the GI so that they can catch them, when they are just in the polyp form, which are completely non-cancerous generally speaking, kind of there, so that they will not develop into colon cancer. And I cannot tell you how many times patients were completely normal. They go and see their primary care physician for their well visit, and they just kind of say, you're 50 years old and you're not having anything, but now you're due for colonoscopies. They will go for colonoscopies, and we will find that they have colon cancer, and then the whole process starts of the surgery, chemo, and all of that part. So it's very, very important to understand that, it's a test, it's 2 days, but, if you get a clean chit or if you have a polyp and we take care of it, then, something really more sinister can be prevented. I cannot tell you enough, because when we don't do it, then more things have to kind of come by. Another place that we would offer colonoscopy, because I see a lot of them, and those are the ones that I will refer them to Paola, are the ones who have anemia, right? Anemia is low hemoglobin. So patients who have low hemoglobin and they are iron deficient, that we will find that out on their blood test. I will always send them to do an endoscopy, or I will do a stool test to make sure that they don't have blood in their stools, so that we can find out that there may be a polyp which is sitting there and bleeding from time to time, or there is a cancerous growth which is sitting there, which is bleeding from time to time. So those are generally the most common times when we would send the patients for colonoscopy.
Yeah, that's absolutely correct. So I tell patients you have alarm symptoms that we're always looking out for, and it really doesn't matter your age, but if a patient comes to me and they've had blood in their stools, they've had a significant change in bowels, a change in shape and the size of their stool, they've having, severe abdominal, rectal pain, unexplained weight loss, and like you said, new onset anemia, those are sort of like the red flags that say, okay, boom, boom, this patient needs to get a colonoscopy. And that's, regardless of their age. Like you said, it's very unfortunate, but I have seen colon cancer as young as 30-year-olds, 20-year-olds. So, if you're having any of these symptoms, certainly, please, seek help, and so that we can determine what could be the cause of it. Now, but, like Dr. Gupta mentioned, everybody who turns 50 is going to get a colonoscopy. So many times patients say, well, I don't, I'm healthy. I have a very healthy diet. I don't smoke. I don't have a family history. How did I get this cancer? And that's the thing. It's, that's why it's so important that at 50 that you get a colonoscopy. So many times those patients are now seeing me and 10 years later, and they're 60 years old and they're waking up and I found something that I'm concerned about. And they just can't believe it because they had no signs or symptoms. They had nothing that could have caused them. So it's just one of those tests. It's torture for, that one day, but then you can have sort of a peace of mind that, that the polyps were found, that they were taken care of, and the risk of colon cancer decreases.
I know I have diverticulitis, and that was what originally they scheduled the colonoscopy for. And my sister-in-law had the same issue, but they found that her colon was actually had ruptured and she was leaking. And had she not gone for the colonoscopy, she would, she was in a very bad way at that point. So I know that for her, it really saved her life to have the colonoscopy. And it wasn't for cancer, but it was for colon health for sure.
Yeah, I mean, diverticulosis, which are sort of these pockets that you get in your colon, those are just sort of what I try to explain to patients, like stretch marks of your colon. Like you get stretch marks of your skin, there's stretch marks
Right.
of your colon, sort of these out pouches of your intestine. That doesn't put you at risk of developing colon cancer or colon polyps, but you can develop complications like diverticulitis or perforation and things like that. So you want to make sure and know if that's what you have, we can treat that as well. But it's one of those, again, a lot of times patients wake up and they didn't even know that they had these pockets. Thankfully, most of the time they don't really cause any symptoms. You probably were one of the few that, unfortunately got the diverticulitis.
It really was quite something to deal with. And, I've learned a lot about my own diet, not eating seeds or corn or all those things that, I love and have had to eliminate from my diet, nuts. So, you do kind of learn about your body as you go along when you have issues with your GI tract.
Mm-hmm. Mm-hmm.
So I turned 50 this year.
Yay!
Oh,
The
Oh,
magic number.
yay. So you're ready for your colonoscopy.
I know, it's on the list, believe me. Well, I figure like I'll do it between my birthday and Christmas. It'll be like a Christmas gift to myself.
Merry Christmas
But
to you.
There are a lot of people I know out there who are just terrified of getting this done. And how do you deal with people like that? Like, what do you say to somebody who is scared of A, sedation, B, just the concept of what you're doing? Because I actually, when I was really young, I worked in group homes for people who are developmentally disabled adults, and adults need medical care. And I had a client that had to go for a colonoscopy, and she wouldn't do it unless I went in with her.
Oh,
Wow.
She wouldn't do it unless I went in with her. So I saw how they did it. I saw how they did it, and I saw like the pictures, which are really amazing, like from the camera that the doctor looks at. But how do you get people to a comfort level of this? Because there are people who are very
that's a
scared.
great question. Yeah. We just, blindfold them, tie them up, and then we just shove the, I'm kidding. No, so,
Like seriously, if somebody saw the equipment, you might have to do that.
so a couple of things, so I ask patients, what are they afraid of? A lot of them is the anesthesia that they use. And I'm sorry, I don't know how to turn the beeping message from the computer off, so I apologize for that. It's, a lot of, like I said, that a lot of times the patients are afraid of going to sleep. They've never had anesthesia in their lives. They've never been sedated, and they feel like they're not going to be able to wake. What if I don't wake up? What if I have a reaction with anesthesia? So the type of anesthetic that we use is something called propofol. Propofol is very, very short acting. So once they basically administer that to you, so you get an intravenous, so you get an IV, and that goes through your vein, and it works within literally, a minute, and then you're awake once it's done. So you don't have sort of that after effect that that you don't feel well, that you can't wake up. You're breathing on your own. So it's not that you're still maintaining your airway. You're not connected to a breathing machine. And we have licensed professionals, nurse anesthetists and anesthesiologists that are keeping an eye on your airway, make sure that you're breathing okay. If you have a lot of risk factors, cardiac disease, a lot of patients who have a lot of heart disease, lung disease, they're afraid to go under anesthesia. Then we'll do those procedures at the hospital where we have a little bit more equipment that we're able to treat those patients. But if you're healthy and you don't really have any medical problems, then an outpatient endoscopy center is perfect. That way you don't have to go into the hospital now. Especially, with obviously the COVID cases and so forth, people were even afraid. So that was the big thing, now is not only the anesthesia or the procedure, now it's COVID, right? So that's one of the big, the big things for us, and especially for colon cancer screening, is that patients did not want to get screened. I had a lot of patients that were supposed to get their colonoscopies last year, and now they waited another year, and there was already a precancerous growth, or there's a cancer in their colon because they were afraid. So, if you would see me doing procedures, I mean, we're covered from head to toe. the physicians are protected from you. And so it's a very different environment than when we used to do colonoscopies before. And then once, when we're doing the procedure, the patient is asleep, so you don't actually know or are aware of what's going on. And the scope that we use is as thin as my pinky. So, so you won't even know. I think a pap smear, to tell you the truth, is worse because you're awake and it's just so awkward, the whole situation. And then the doctor is asking you all these really strange questions and you're like, just get it over and done with. But with a colonoscopy, you're asleep, you won't even feel that. But I think a lot of patients, their fear is the anesthesia. So just trying to understand what is it they're afraid of. Certainly, any procedure in medicine, it's not risk-free. So obviously, if depends on the operator who's doing the procedure, we talk about the risk of a perforation or bleeding, which thankfully is very, very rare. And now we have really great sort of scopes and techniques that we use that years ago we had very rigid, very unflexible tubes, if you may, that caused higher complications. And now, thankfully, we don't. And it's, high resolution. So the risk of missing polyps or cancers, things like that is very rare as well. So I think it's just trying to educate the patient, really understand what their fear is. And unfortunately, like Dr. Gupta said, is that a lot of times patients, once, they let it go, okay, I don't want to have my colonoscopy. And now they're like 55 and 60. And I find a cancer so preventable. If we would have removed that polyp at the age of 50, it wouldn't have gone to that. And now, like she said, now she's seeing them, they're getting a CAT scan. Do they need chemotherapy, radiation? They're undergoing major, surgery. So right. It just opens this whole, can of worms that is just something that is just so, it's very tough on a patient. I'll never forget, I had seen a patient in the emergency room. She was 48 or 46, had not reached 50 yet. And she was anemic. And I had done her upper endoscopy because she was on a lot of NSAIDs, and NSAIDs can cause ulcers in your stomach. So we thought that was the cause, but I did her endoscopy and it was normal. There was nothing. And her hemoglobin was low. So I said, look, you really need a colonoscopy because I really think that there's something else going on. She was discharged, she went home, and thankfully she followed up and she followed my recommendation. And when I did her colonoscopy, she had a very big mass in her cecum. And so if she would have waited until she was 50, that could have gotten worse. She underwent surgery and it was stage 0. So she didn't need chemotherapy. So she was cured. So that was huge, Yeah. So she wouldn't have followed through with that. By the time she was 50, which was in a few years, that probably would have spread everywhere. And then the risk of the survival as patients get to a higher stage, stage 4 has affected their liver and has, spread, the mortality is much higher. But if you catch it early, then the risk of a complication is less.
I really don't think that I'm going to have a problem with it. If I can, I have a male guy. I've had a male gynecologist. Like if you can go to the gynecologist and have a conversation with a guy who's going to do all that, you can do this. Like
don't worry.
I would think that men would have more of a problem with it because they don't go through such a regular invasive, not procedure, just examination all the time. Like we're kind of used to people looking at our business, right. And they aren't, So do you find that men have a harder time?
Oh yeah. Yeah. It's interesting. I mean, my population I have a lot of females. That's sort of what I do. I take care of all the women, so I'm happy to take care of you. So so most of the time it's my patients, the husband, they're bringing their husband in, their boyfriend, their brother or their father. So then I ended up doing the brother, the father, so they're convincing them. So thankfully I have the power of my female patient to convince them. But yeah, absolutely. Especially men, they're like, no, I'm fine. I have no problems. I don't go to the doctor. Why am I going to get this, and just to think of the whole procedure, they feel violated itself, right?
Mm-hmm.
And you try to, you explain to them what it is. And then when they wake up, they're just like in awe. They just, I can't believe it. I had polyps. I don't have any symptoms.
Right.
I tell them, yeah, and these are the precancerous kind. If you would have waited, you wouldn't have had this done. These are the polyps that would turn into cancer. They're gone. They're removed. I'll see you again in 3 to 5 years. And the patients are like, well, is there anything I could have done to prevent them from forming? And that's the thing, there isn't. I mean, they looked at diet, vitamin E, vitamin C. I mean, all that helps to have obviously a healthy diet. Obesity, there's a higher risk with obesity and colon cancer, but there's nothing that you can do to prevent polyps from forming. So I think once the patient understands that, one of my patients I saw is like, I'm bringing my buddy. Like, he's this Greek guy. He owns this business. He's this tough guy. He doesn't want that done, but he needs it done. And he's like, you saved my life. You're going to, you have to do his colonoscopy. So it's just sort of the word of mouth and trying to educate patients.
So two things. So just as far as Dr. Blanco said, as far as the anesthesia is concerned, it is propofol. Actually, most people will say this was the best sleep I had because it's a very refreshing sleep. And when they are actually kind of injecting it, you fall asleep. When they stop injecting it, you wake up, and there is really no after effect. So it is very, very safe anesthesia, and it's anesthesia, but not a general anesthesia. So there's no kind of harm. That's why we are able to do it in the outpatient setting. So she talked about a couple of things that I would like to ask a little bit more for our audience. So Dr. Blanco, I want to ask your opinion about the Cologuard, right? The kind of those tests, because I see a lot of patients that I'm seeing now, and I say, you know what, you need to kind of go for your routine tests and your colonoscopies or my iron deficiency. And just last week I saw this patient. She says, no, I'm good. I just got my Cologuard done, and a lot of insurance companies are sending the Cologuard now to their homes free of cost. So tell me a little bit about that. I myself really don't know about it. Like, what are the guidelines saying that how many times we can get a Cologuard and then we still have to do a colonoscopy, because like you mentioned before, that they can be falsely positive. That means that there is no polyp or colon cancer, but the test is showing that something is wrong. So can you kind of just, I think people are always looking for non-invasive tests. And so talk a little bit about that.
Sure. So the two tests that you're going to see most commonly is, like I mentioned, the FIT test, which looks at the hidden blood in the stool. And that is usually performed on an annual basis in your primary care's office. Now, remember, this is going to be positive if you have hemorrhoids, if you have a history of straining, because it detects blood. The other test is a multi-target stool DNA. And basically what it does, it looks at abnormal DNA that's associated with both colon cancer and colon polyps. It's more sensitive than the FIT test, but it also has a very high false positive. So in meaning that you can have a positive, a multi-target stool DNA or the Cologuard test, and then do a colonoscopy, it's negative. So if it's negative, the repeat screening is recommended every three years. Insurances won't cover it every year. Now, unfortunately, because this test is using as a screening tool, a lot of insurance companies, so when you turn 50, 100%, it's covered your colonoscopy because it's preventative. But once you have a positive test, then that's considered a diagnostic colonoscopy. So that's not covered 100%. So it goes a little bit, in terms of, deductible and, little semantics about insurances, and all insurances are different. But now patients are having to get what they call a diagnostic colonoscopy because the initial screening test, which they use as a stool test, was positive. And unfortunately, these tests are not perfect. Certainly we all don't want to do the prep, and we don't want to go under sedation and having to, to go through this invasive test of a colonoscopy, but it's not perfect. So then what if and that's sort of where it gets sort of the gray area. What if the stool DNA test is positive and the colonoscopy is negative? We don't really know the guidelines when to repeat it. Now, do you look at, anything in the small intestine or the stomach? Is there why did it become positive? So it becomes a little bit on a gray area. That's why I'm not, so thrilled about the stool tests. Certainly, I'm glad patients are getting something. I have patients who are 65 and they come to see me in the office, and I ask them, is this your first colonoscopy? And they say yes. And they say, well, my doctor never told me that I should get a colonoscopy. That happens many times. I heard it on TV, or I saw, a show on the Today Show. And thankfully, like you said, March is Colon Cancer Awareness Month. So there's a lot of things on TV and so forth, but their doctor never mentioned it. So I'm glad they're at least getting something, but I do feel that doing the colonoscopy, it's a one-step test that looks for the growth of these polyps. You can detect them and remove them during your colonoscopy and then prevent colon cancer. So obviously this offers sort of long-term protection against colon cancer. So that's why I feel sort of the first step, which is a screening test for the colonoscopy, is better. But, if patients are doing the other way, and that's positive, then we can talk to them about what the next step is. Certainly if a FIT is positive, if the Cologuard is positive, then definitely the next step would be a colonoscopy to figure out why it is positive.
So they will still need that to find out and to do the biopsy and removal.
Yeah.
And Dr. Blanco, right now, I know that from our literature in the cancer world, right? So we are seeing that the colon cancer is happening a little bit more earlier than 50 years. In fact, there is a talk that the age for colonoscopy should be decreased to 45 years, though the standard is still 50 years. But those patients that we are seeing who are less than 50 years of age and coming with colon cancer, they have more advanced disease. It's already gone to the liver. And part of that is because if they're young, or like Dr. Blanco said, that her patient was 30 years old. Actually, my most difficult patient so far, and this was in 2009, 2010. I was a young attending at that time. I get a consult from this 28-year-old female. I don't think so. I will forget her till the end of my life, honestly speaking. So she was 28 years old. She was pregnant, and she was telling her gynecologist and OB that he's having incontinence of her stools, and she was losing weight. But they all said that, they did the exam, everything seems to be okay. And they said, oh, you know what, all your muscles are very lax and this can happen. And this was in the last trimester of, last few weeks of her pregnancy. And because she was pregnant, they could not do any other testing, right? So she had the pregnancy and she was 3 days postpartum. I cannot forget. I have that whole vivid memory in my mind when I entered that room. And the baby was kind of not there at that time, but this poor woman was sitting there, and there were 15 people in her room, mom, sisters, friends. And so she got a colonoscopy done because her incontinence did not get better after the birth of the baby. And lo and behold, she had stage 4 colon cancer. It had already spread to her liver, and then she fought for 4-5 years. And unfortunately, she lost the battle, she got 5 good years. So I am very, very fearful. So the moment I hear any change in the bowel habits, any blood in the stools, or iron deficiency, anemia, all my patients would get a consultation, because like Dr. Blanco said, it's really preventable. I mean, the situation was such that we could not do that. So it's very important that even if they are young patients, 20 years, 25 years, that they would have any bleeding. And even if they think, oh, this is all hemorrhoidal bleeding, that is the most common thing that we would get. It's always better to get the colonoscopy done and at least check with your doctor what is happening. And part of the reasons that they are diagnosed is the biology, that we feel like the younger ones have a different biology about the cancer, but the other is also that there is always a delay in their diagnosis because nobody's thinking about colon cancer in a 28-year-old or 30 years old. I mean, who would think about that, right? So there's a lot of literature in our world, Paola, about a plant-based diet and prevention and constipation as a risk factor, diet as a risk factor for colon cancer, right? I mean, there's a whole microbiome and plant-based diet. I mean, I'm throwing a lot of words just as kind of as a segue for Dr. kind of Blanco to talk about a lot of those things there. So any thoughts? Again, part of our education is also to tell what we can do to prevent colon cancer.
Yeah, no, absolutely. And like you mentioned that age, I remember seeing a 32-year-old as well with a stage 4 colon cancer. And it wasn't, she was having severe abdominal pain, and her doctor kept telling her it was irritable bowel syndrome or IBS. And when, we did the workup, it already unfortunately had spread everywhere, and she passed away a year later. And like you said, it's not, you wouldn't be thinking about it. So she probably had this mass maybe in her, late 20s or early 20s. So to think of it already had progressed by the time I saw her. So it's something that is, you really would like to prevent. So like I mentioned, all those different sort of risk factors. Like I said, the family history of colon cancer, if you have a family history of polyps. So I have patients who tell me both my parents had polyps starting at a young age. So those patients, you want to get screened. Cigarette smoking and obesity has been linked as well to high risk in colon cancer, certainly in patients who are sedentary, unhealthy diets. So all that, puts you at risk. If you had any abdominal radiation, uterine cancer as well. If you're younger than the age of 50, that puts you at risk of colon cancer. And most recently, we know African-American race, the actor who played Black Panther, he died and he had colon cancer at a very young age. And I think that was a huge awareness to the African-American population, saying, okay, you know what, I need to get screened. Unfortunately, the insurances, they don't cover at 45 yet, but I think in the future they will, because like you said, we're seeing at such a young age patients who have colon cancer that it's hopefully we can start detecting these earlier. But if you have any of these risk factors, smoking, obesity, sedentary lifestyles, all that is going to put you at risk. So sort of those things, those alarms and things in your head that you need to get screened.
I would imagine that if you're over the age of 50 or over the age of 60, you've had your colonoscopy, but if you start to see changes, you should
Oh, absolutely. Yes.
report that to your physician, go back to your gastroenterologist, and
Yeah, absolutely. Yeah, I mean, that's a very important point. I mean, I've had patients, oh yeah, I had my colonoscopy 3 years ago, and all of a sudden they notice a sudden change. They were told to come back in 10 years. And then some patients, for whatever reason, they get polyps that tend to form a little bit more aggressive and quicker. So you just want to be on top of it. So even if you had your colonoscopy and if you notice a sudden change, then absolutely, I would, seek, help. Now, after the age of 75, if we don't find any polyps and if you don't have a family history, we actually stop screening for colon cancer, because the older you are, the higher the risk of a complication. So if you're 80 or 90, you're not going to be getting these, these colonoscopies. So, but if you again had your colonoscopy at 50 and then now you're 55 and you notice a sudden change, absolutely get your colonoscopy. Seek medical attention. That's a very important point.
Yeah, with my grandmother's 96 years old. The least amount of medical attention that she has to go through, the better. So, when you get to be up there,
Oh, yes.
she's really up there. Whenever the doctor suggests anything a little off the charts, we're like, nah.
No.
She's the healthiest person I know, by the way. She's 96 years old.
She did something good to kind of reach to 96, Holly.
Well, every woman in my family really lives over the age of 90.
You have
Right,
Wow.
Sarah? Yeah. How old was your mom when she passed away?
she was 97. She
97.
passed
Oh, wow.
Yeah. My
January.
other grandmother was 90. She made it to 90, but my alive grandmother, who's 96, she has nothing wrong with her. She's blind. She lost her vision, but she has zero health issues.
Oh, that's great.
No medication.
Awesome.
Well, my
I'm on
grandfather,
more medication than she is. So, to all be so lucky.
my grandfather lived to, he was 98. He would tell me, I never go to the doctor because they always find something wrong with you. I don't know if that's the right attitude.
I don't know either. I don't know.
If he's 98, then it's okay.
Yeah, he's fine now. He
Really
can do whatever he wants.
Exactly.
It's one of the most preventable cancers, right? So or treatable. So if you go and do these tests and you go and have things removed and you have things biopsied, what are the odds for people, so that people understand that a little bit better?
So it's, and like you said initially, it is one of the most preventable, because when we're looking again for these little polyps that are sort of like mushrooms, and remove them, and then your risk of that turning into something bad is back down to zero. Now, treatable, the good thing with colon cancer, it's not sort of like the pancreatic cancer, esophageal cancer, it doesn't spread so quickly. So even if we are diagnosing patients with colon cancer, like I mentioned, that young female patient that I had, we found it in its initial stages. So it hadn't spread to the lymph nodes and to, you know, all the organs nearby in the liver. So thankfully it's slow growing. But we don't want to get to that, you know, get it to that stage. So what we're looking for are these polyps that if you remove them, then the risk of the colon cancer goes down. Now, patients ask me, you know, what can I do so I don't get polyps? You know, why? And that's what we really don't understand, is that as your cells are turning over, you have abnormal cells that form these precancerous sort of bumps, and patients, I call them my polyp formers. You remove a few polyps now, and then a few years later, they form other polyps. So patients have different genes that predisposes them to forming these polyps. And you just have to be on top of them, getting their colonoscopies and removing them, because every time you remove them, the risk of colon cancer goes down.
And can you explain to people about maybe what the size of a polyp would be equal to? You know, is it like a grain of rice, or what would the size be?
Yep, it could be a few millimeters in size to maybe like a size of a peanut. So those tend to be larger, or it could be encompassing sort of the whole entire surface of the colon. So it can vary. Those and within sort of the sizes, there's different types. There's flat polyps. Those tend to be more aggressive. That's why the colonoscopy prep is so important, because if you're not cleaned out well, it's really hard to see those. So those are the flat, what we call serrated adenomas. So those are really difficult to see. And then the bumps that look sort of like mushrooms, sometimes they can be very little. They could be what we call pedunculated, meaning they could be on a stalk that we can remove them. So there's all sorts of different types. But that's why it's so important to do your prep very well, because or else we can't see. And I can't tell you how many times I've done a colonoscopy and the patient didn't follow the instructions, you know, adequately. They didn't do the prep. They did half the prep, and then they wake up and I tell them they're going to have to do it again, because I was only able to go a certain distance because I wasn't able to see anything. So that's why the prep is so important. And you know, and patients wake up, they're like, you did it. I'm like, no, my job is easy. It was your job that was the hard part. So yeah.
Well, I say that I did the Miralax with Gatorade. That was the prep that I did. I will never look at lemon or the yellow Gatorade the same ever again. But I was so thankful to get the news that I didn't have to go back within 10 years. But my question is, if you do have to remove polyps, is there anything, you know, after you wake up, do they have to rest, or is there any, you know, any cautionary measure that they have to take after they have had polyps removed?
No, not at all. I mean, your GI tract, you can burn, you can cut, it doesn't cause pain. It's a distension that causes pain. So the receptors that they feel is anything that's distended. I don't know if you've ever had, you know, your belly swollen or puffy, that's very uncomfortable. So that's a distension, but the cutting and the taking out the polyps, the patients don't feel that. Certainly when you remove polyps, there is a risk of a bleeding, much less risk of a perforation, but that's rare. And we do have methods that we would do to prevent that from occurring. Sometimes we can put like little clips around that polyp that was removed, because the polyps sometimes can be very large. So we don't want them to bleed. So we have those sort of preventative methods that we can use. But no, it's after the day of the colonoscopy, because they get propofol, they can't work. So that day I always tell patients you have to take the day off. They can go to work the day prior, fine, because the prep doesn't start till much later in the afternoon. They just have to be on liquids. And so they can go to work the day prior. So it's just that one day they can't go to work. And then the following day, after the colonoscopy, everything is back to normal. So really, no, they really wouldn't have any problems.
I know.
I'm sorry, go ahead.
No, okay, go ahead, Ranju.
On the day of their colonoscopy, they do need a driver, because, you know, they got anesthesia, so we do not allow those patients to kind of drive on their own back
Oh yeah, that's very important. Yeah, I've had a couple of patients who have
Yeah.
walked to the hospital thinking that they're going to walk home. They can't do that. You can walk with someone, but you need somebody to accompany you, because even though, like Dr. Gupta mentioned, I mean, the propofol, it is the best SNAP. I mean, some patients are like, can I take some home? I would love to, this was like the best sleep I've ever had. But no, we can't give you some to take home. But because
Might actually be something for me to look forward to, because I
There we
haven't been sleeping.
oh yes, it is. They say the best nap there is, and so that because even though you may feel like you could go drive or and do things because you did receive anesthesia, you can't do work, or I tell patients can't operate heavy machinery or make any important decisions. So that day you get the day off, basically.
When I had my endoscopy and colonoscopy, I had them on the same day. And actually, they woke me up between the two procedures, which I thought was very odd, and kept asking me if I was okay. And then they said, "Oh, well, we're going to put you back to sleep now." But I've tried to find out why they did that, and I can't seem to get an answer from from anesthesia or the doctor's office, because I've had an ongoing care regime with the doctor's office, but they don't really know why I was woken up between the two procedures.
So it's hard for me to say, but the one thing I can sort of attest to is the propofol is very short acting. So it probably just wore off. And as they were, so normally if you have an upper endoscopy and a colonoscopy, just to explain to our, who people are looking with this video, is that we look at your esophagus, your stomach, and your small intestine with one tube, use a separate tube, we turn you around, and we do the other end, which is take a look at your colon. So sometimes in that process, because you're not really doing anything, we're just swinging the bed around, patients will wake up. So that's normal, that's all right.
Oh, okay.
As long as you're back to sleep again, that's no problem, because it's so short acting that once they stop the medication, then you will, you'll wake up. So, so as they were swinging the bed around, you weren't receiving any medications because you weren't, having the procedure, and then you woke up. But that's okay. That's normal. As long as you went back to sleep again, that's okay.
Oh yeah. You're right. It was a great sleep. I must say, I felt very rested when I woke up from the procedure.
Mm-hmm.
There have been a couple times in my life that medical treatment has made me feel better. It was funny. I had a gallbladder surgery. I've had a lot of surgery. Actually, now that I'm thinking about it, it's like I had a cesarean section, I had gallbladder surgery, I had wisdom teeth taken. I've had a lot of sedation over the years. And to hear that it's something that isn't going to make you feel sick after is very comforting, I think, to a lot of people, because if you've had sedation before, that waking up process makes you feel really weird. You don't know where you are. And then you have to stay for so long to make sure that you're okay to go. And I usually wound up going home with a bag in case I didn't make it all the way home.
Yeah.
But that you don't get that with this, correct?
No, because we just only use propofol. If you're using narcotics or benzodiazepines, those tend to make patients sick and make them very lethargic and not, just don't feel well. But we only really use propofol unless a patient has other medical conditions that we need to use. The anesthesiologist needs to use something else. The anesthesia part, I leave to the anesthesiologist. I tell them I do the colon part, they figure out the anesthesia part. So, we have trained professionals who do that. So sometimes, patients may need another type of medication to keep them comfortable and asleep. And that's fine because everything is in a monitored, very controlled setting. But most of the time, they're only given propofol, which is very short acting.
Good to know. I think that's really good to share like that, because it is amazing how the sedation causes more questions and concern than the.
Oh yeah, I mean, especially if you've never had surgery, just to be put on, to be put asleep just makes patients, a little bit eerie, not being in control and not knowing what's going on and, what to expect. And obviously, the news has a great way of just making anesthesia. Sometimes you hear these horror stories, but it's a very controlled setting. And like I said, I'm the one who's doing your procedure, but we have a trained, licensed nurse anesthetist, anesthesiologist, so physician or nurse anesthetist who are trained to, to take care of the anesthesia part. So I can do my job. And so they can take care of your heartbeat and your blood pressure and your airway, where I don't have to worry about that. So it's a great, very, very controlled setting.
The good part also, I think that the reason people are so scared of the anesthesia is because everybody has heard from their parents or grandmothers that they got anesthesia, there was a complication. Some of the really, really old folks would also say, if you are getting anesthesia, you're not going to come out alive. Like, that kind of sense used to be there. I had my father get a colonoscopy in India, and there they do not use the sedation because then you have to get an anesthesiologist, and in the government hospital sometimes it's very difficult because the volume is very large. My dad has never forgiven me for that. Because he
Actually,
so
we have somebody in the chat room who did mention that in their 40s she had one and they did not sedate her.
Yeah, my dad
yeah,
angry with me even to this date.
Yeah.
Well, my sister, I'm from South America, and my sister had upper endoscopy without sedation, and she doesn't forgive me to this day either. So because they don't use sedation down there, they just stuff it down your throat. Yeah. So yeah, no, not here. Not here.
I
Not
have done
in the
them.
US.
I have done them for my patients. When I was doing my post graduation in India, and the endoscopy was still easier. Right, but the colonoscopy, you guys have to move around the colon and you have to put air into it. My God, my dad, even today, like he's like, why did you do it? And I begged them, but they wouldn't do that. That was not the protocol. They didn't have an anesthesiologist there.
Mm-hmm.
Yeah, you have a lot of family issues, but to add a colonoscopy into it. Well, I think that everybody who's watching should put in the chat room whether they've had it or not, whether they're scheduling it or not, and we could all answer questions about that. Sarah has had one.
Yes, I have.
I remember when she told me, didn't you tell me that you went in like in your hospital gown and you came out and you were dressed or something like that?
Oh, that was
for this?
No, that was a different surgery.
Oh, that was a gynecological thing. Huh? See, we have so much going on that we can't remember which surgery it was.
I had a gynecological thing where I went in and they had me change into my hospital gown, but when I woke up, I had all my clothes on. It was kind of different.
That shouldn't be there. I don't know what happened there, but
no, we won't be doing that during after your colonoscopy.
That was the weirdest thing I ever heard. What were they doing?
Yeah, I don't know. But I would like to add a little bit about the diet. I mean, I think that what we have seen, at least in our oncology kind of literature, is that plant-based diet. We do find that the risk of colon cancer, not the polyps. I mean, I don't have any data about the polyps that I can talk about, is much less, say, in African countries or some of the developing countries compared to developed countries like America or Europe. And part of the reason that we believe that is there is the diet, because the diet, there is more plant-based diet that is there. They eat a lot of raw food, cooked, but like more plant-based. Here we are all these very refined food like pizzas and all of those things. They don't have the fibers in them, and that could be a cause for constipation and also for colon cancer. And there's a whole lot of kind of research going on about microbiome that you're hearing about. How many people are now wanting to be vegan or plant-based diet. Nobody is saying that you cannot have meat. Nobody is saying that, but we are only saying that you should try to eat more fruits and vegetables in your diet. Like, the balanced diet is what we're talking about. We have not shown that only vegetarian diet is more useful, but a balanced diet with a lot of fruits and vegetables in your diet is really, really, really important. They have been able to find certain bacteria that was found in the good bacteria, and the colon cancer is less in some patients, or the bad bacteria in the colon has been found in the cancer in the liver. So we do believe that this whole prebiotic, probiotic, kind of all of that, has come from that diet part that, there. So I do want to tell our audience that, please pay attention to what you're eating. There is something to be said about that. What you eat is very important. And this is the only cancer which is preventable. Because even when we are going for mammogram, I'm not preventing a breast cancer. I'm just helping it diagnose it when it is very early. I can't change a breast cancer. There's nothing that we can find like that would be akin to a polyp, which is precancerous like that. So we are just doing a mammograms and finding cancers when we are very small, so we can get away with less treatment. But colonoscopy is the only test that at least I know of that is actually preventative. That if we can find them at the stage of their polyps and we remove them, then they do not go and develop into colon cancer. So it's very, very important. It's just a test. We can kind of feel awful for 2 days, maybe 2 days. Maybe it doesn't like maybe 2 days. I mean, some people like kind of anesthesia, taking time off, 2 days. But every 10 years, it's a small, small price to pay for our own health. This is our health that we are talking about. So whoever is kind of watching, we got to take care of our health and our family members' health. So it's very important to keep that in mind.
Yeah, absolutely. And the other thing I wanted to mention about the diet that I recommend a lot of my patients is also the Mediterranean diet. There's a lot of studies that show a lot of anti-inflammatory effects doing a Mediterranean diet, especially in patients who, have Crohn's and colitis. It seems to have a lot of anti-inflammatory properties. So that's a big one I also recommend my patients. But, like you said, sometimes, patients may be the healthiest person, doesn't matter, if you turn 50, you want to make sure and get screened. You want to take care of yourself because nobody else is going to do it. So, I tell all my friends that, okay, you're 50. Okay. What's your number? What's your phone number? You're going to get a phone call. So already there's, they're already in, it's already done. So it's not, it's so important. So everybody that knows me, it's there. That's it. That they
don't like you. They don't call you.
That's their 50th birthday present.
So they don't like to call you on their 50th birthday.
No, I give them the prep with a big bow. I'm like, happy birthday. Yeah.
And fiber is the thing that they're always preaching to me to make sure that I have plenty of fiber in my diet.
Mm-hmm. Yeah.
That's a whole other show, diet, nutrition. That's a whole other show. But this has been, I think, really informative. Thank you so much, Dr. Blanco, for joining us. It was wonderful information. Our folks in the chat room have been chatty. They're really into it, and we hope that everybody got great information from our chat. Thank you, Dr. Gupta, for joining us for our monthly health chat. We are so excited every month to bring something different to everybody. We will be back at the end of April with our next one. We haven't come up with a topic yet, but we will come up with something fun. Something fun will come along, I am sure. We want to thank our sponsor, My Girl Managed Services. They bring us to you every week. Without them, we could not be here. If you need help with your business's social media, Google presence, or your website, make sure you check out My Girl Managed Services. Jen Narkovich and her team are more than happy to help you. Sarah, it's been a good one, right?
It has been a great one.
Good night, everybody. Thank you so much.